Welcome to today's webinar. County Health Rankings and Roadmaps is a program of the University of Wisconsin Population Health Institute. This webinar is brought to you thanks to the contributions of colleagues and partners in Wisconsin and across the nation, with support from the Robert Wood Johnson Foundation. It is produced in collaboration with Healthy Places by Design, an organization that advances community-led action and proven strategies to ensure health and well-being for all. The University of Wisconsin-Madison occupies ancestral Ho-Chunk land, a place their nation has called Dejo since time immemorial. Today, UW-Madison respects the inherent sovereignty of the Ho-Chunk Nation, along with the 11 other First Nations of Wisconsin. This webinar will be recorded. All speakers' views are their own. Guest bios and slides from today's webinar are available on our resource page. We will share a link to the resource page when the webinar begins. Stay up to date on all things CHR&R. Find us on Facebook, X, and LinkedIn. And if you haven't already, sign up for our newsletter by scanning this QR code with your phone's camera. It's the best way to find out about upcoming webinars, our podcast, and our latest tools and resources. For your convenience, the QR code will also continue to be displayed for the remainder of this short video. We invite you to continue the conversation. Join our discussion group immediately after the webinar. Joanne Lee will be our lead facilitator. And watch for a chat from Soraya for details on how to join the group after the webinar.
Hello, and welcome to How Public Health Can Navigate Communication Challenges. My name is Soraya Williams-Neal, your host for today. The purpose of our webinar is to share successes and lessons learned, offer relevant resources, build collective knowledge, and listen from multiple perspectives. I want to note that the views of CHR and our colleagues share in the webinar reflect the expertise of more than 35 team members and do not represent the University of Wisconsin-Madison or the Robert Wood Johnson Foundation. And I also want to acknowledge that funding support from the Robert Wood Foundation is appreciated. CHR and our webinars reflect the values we hold as part of the University of Wisconsin Population Health Institute. Values of collaboration, innovation, integrity, courage, inclusion, and excellence. And these are values we aim to model during the webinar, and we hope you will too. And with that, I'm pleased to introduce the team supporting your learning experience today, and we will begin with Joanne Lee from Healthy Places by Design. Hello, Joanne.
Hi, Soraya, and hello to everybody out there in our audience. We really appreciate you being here today, and we want to invite you to join the conversation and engage with us during today's webinar. And there's two ways to engage. One is if you have a question for our panelists, you use the Q&A box, and that is in your Zoom menu. We'll answer as many questions as we can during the live webinar as possible. But remember, we can also address questions during the post-webinar discussion group. The second way that you can engage with not only us, but other participants is by using the group chat. And the group chat, many of you now are being prompted by Erin, who's monitoring the group chat, to introduce yourselves, but also use it to comment on learnings or share your knowledge and experience with today's topic so everyone can see it. Now I'm happy to introduce you to Erin.
Thanks, Joanne. Hi, everyone. I will be seeing you in the chat today. First, to be able to participate fully, be sure to change your chat setting to everyone. And you'll see that our chat gets very lively. So we ask that you please adhere to our group agreements for a more productive interaction. And then for more about our group agreements, please see our webinar resource page, which is one of the links I will be sharing. And now I would like to turn it over to today's technologist, James.
Hi, Aaron. Thank you so much. My name is James Lloyd. I work with County Health Rankings and Roadmaps, and today I'm working as the technologist. So we want your experience with Zoom to be the best it can. And if you have any issues, reach out to me in the Q&A pod. That's the best way for us to have a conversation and try and solve any issues you might be having. So I am very much looking forward to this conversation. Have a great webinar, and back to you.
Oh, me too. I'm excited about this. Well, thank you all. Well, today's topic, words matter, especially in public health, where complex issues meet diverse audiences. The way we talk about problems and solutions can either build bridges or create barriers. Language reflects and reinforces both the written rules, like laws and policies and budgets, and the unwritten rules, like social norms, cultural expectations, and shared narratives. And those guide how communities experience health and opportunities. The words and stories we choose influence how people understand health. Rather they see it as an individual responsibility or as something shaped by the societal rules, systems, and conditions around us. Our messages and frames carry the narratives and worldviews that help people make sense of how society works and what kinds of solutions feel possible. In short, language can either strengthen trust or erode it, and it can guide the decisions that shape our communities and our health. Language is also not neutral. It reflects power and values, and it's often contested. Public health practitioners face growing challenges: politicized debates, shifting cultural narratives, and pressures to reframe or avoid certain terms. Grounding our work in evidence-based communication strategies helps us navigate these challenges. It equips us to share messages that resonate, build understanding across differences, and advance health equity. So we are thrilled to have Jeff Niederdeppe, Professor of Communication at Cornell University, and Julie Sweetland, Senior Advisor at the Frameworks Institute, joining us today. And together, they bring deep expertise on how language and messaging shape public understanding and policy, and how we can use evidence-based communication to advance health equity. Welcome, Jeff and Julie. We are so happy to have you here.
Thank you, Soraya. It's a pleasure to be here.
Hi, Jeff.
Yes. Thank you so much. I'm really excited for this conversation.
Hi, Julie. It takes a minute sometimes to find that come on screen button. Well, you can learn more about Julie and Jeff from their bios on the webinar resource page, and Erin will put that chat in the link. So right after today's webinar, we'll host a discussion group to unpack what you've just heard. So please plan to stay and continue the conversation with us. And as mentioned in the video introduction, our post-webinar discussions are facilitated by Joanne Lee, and they are always engaging, offering a chance to share insights and learn from each other. And Erin will drop the link in the chat at the end of the webinar, so you can join the discussion group. And also keep an eye out for this webinar's resource guide. It'll include links to the materials shared by our guests and the participants in the discussion group, and we will be sending it to your inbox before the end of this week. But now I am excited to start today's conversation with Jeff Niederdeppe. But before we dive into questions, I want to briefly ground us in the importance of the research behind Jeff's work. So his team doesn't rely on intuition or trends. They systematically monitor the public communication environment, synthesize insights from both practitioners and decades of peer-reviewed research, and then rigorously test messages with diverse audiences to understand what truly works. That evidence base has shown time and time again that even topics often seen as polarizing, like structural racism or health equity, can actually resonate widely when framed with shared values, clear explanations, and actionable solutions. So in a moment when public health communication is under scrutiny, this kind of rigorous, replicable evidence feels especially essential. So hello, Jeff. Welcome. Good to have you here.
Yeah, it's a pleasure to be here. Thanks to everyone for being a part of this.
Yeah, so with that grounding in mind, I'd love to start here. So you've studied how language and messaging shape public understanding and policy support. So why is this research especially relevant to public health professionals navigating today's communication challenges?
Sure. Well, yeah, I think we would all agree that we live in a world today in which there are lots of loud and prominent voices that are using rhetoric that labels our institutions and people with opposing political views as the enemy, as morally bankrupt, as advancing ideological agendas. And our public health and medical institutions in particular have been targeted. And, there's certainly many things wrong with our healthcare system. And there are plenty of things that I think that in retrospect, public health and public health communication might have done differently in the past. Thinking about COVID-19, some missteps there. Of course, hindsight is 2020. It's much harder to do this in real time, but our work has shown that the vast majority of the U.S. public is just not as polarized about health and social issues as our elected officials would lead us to believe. So, a major focus of my work over the span of my career, in collaboration with lots of incredible, smart colleagues and collaborators, has been to bring evidence to bear on these questions, to understand how diverse segments of the US population think about health and social issues, and how evidence-based messages about health and social policies can help to build support and action for evidence-based policies that advance health and social equity.
Yeah. So let's talk about that collaborative. So through the collaborative on media and messaging for health and social policy, what have you learned about the impact of communication on real world policy or funding decisions?
Yes, to answer that, I'm going to start by sharing my screen. It's going to take a moment. And I will switch to presentation. Hopefully it will cooperate. All right, can everyone see the slides at this point?
We see your slide. Yes, perfect. Beautiful.
There's always a delay. So I'll just start by saying that a variety of colleagues and I formed the Collaborative on Media and Messaging for Health and Social Policy about 5 to 6 years ago. We're funded by the Robert Wood Johnson Foundation. And we are a group of researchers working at a variety of institutions to bring evidence to bear on questions surrounding messaging around health and social policy. And we're a big group. We span multiple academic institutions. We partner with lots of practice-based organizations in public health and health advocacy. I'm not going to go into detail about all of that, but as Soraya mentioned, I think the sort of 3 pillars of our approach are to understand the conversations that are happening in our media and public environments, to see what kinds of words and frames are being used, how these are evolving over time, to synthesize evidence from lots of different sources, and then to design and test message strategies with a broad cross-section of the US population to understand how different messages resonate or not. So I'll just share a few kind of high-level takeaways that I think are directly relevant to the current moment. The first thing I'll say is that we found over and over that messaging about racial inequality is not inherently divisive if it is done thoughtfully and informed by what we know about evidence-based communication. We have studied messaging about racial inequality surrounding health and social outcomes in a whole lot of topics. You can see several of them listed here, dealing with things like tax policy, dealing with health insurance through Medicaid, through opioid addiction. We've messaged about policies to design healthier neighborhoods, and even using words like structural racism in this message. In these messages, with, I think, sort of evidence-based ingredients in these messages, we can invite people to think about these issues in different ways. We've even talked about unequal impacts of climate change on health, these topics that I think are thought of as inherently divisive. And so, how have we gone about doing this? Well, I think we have learned a lot from communication practice, from communication research, and I've identified a series of sort of ingredients, as I mentioned before, that seem to resonate. Messaging can persuade and mobilize racially and politically diverse groups if, A, it identifies and centers shared values, things that we all across divisive identities can agree on. Messaging that describes the universal benefits of policies in addition to those that address inequality tend to resonate. People want to know that policies that are being proposed are going to work. So talking about evidence about effective policy solutions, talking about how systems and structures can shape health seems to really matter, and using effective storytelling for social change, which is different than storytelling for individual behavior change. I think we've studied extensively and have identified as important. And then finally, I'll say that we've really found it essential to center audiences from diverse political, racial, economic, and sort of geographic locations. And doing so has yielded insights that we wouldn't have otherwise learned from doing this work. I guess I'll end by just acknowledging that none of these strategies are a panacea. Nothing is sort of guaranteed to be effective. The communication landscape is constantly changing. We have to adapt to it as communicators. But I also want to acknowledge that there are real threats to people working in public health and academia, threats to job security, threats to personal health and safety. So I don't want to suggest that these strategies are a sort of magic solution to all of these problems, but they can go a long way in, I think, helping to find common ground among different kinds of people.
Yeah, well, this is a perfect segue to my next question, because public health messaging has faced intense scrutiny, has become politicized, name it. It's tough out here. So, and that's just how we feel as public health practitioners. But what challenges has your research uncovered about maintaining trust and credibility in this environment?
Yeah, I mean, I think a central tenet of effective communication in general and public health communication in particular is to identify credible sources to communicate about issues. We know that purely partisan or other kind of identity cues can cause someone to reject a message outright. Sometimes it's this perception that, hey, you're communicating about this issue, but you're not one of us, you're an outsider, and that can lead people to immediately reject messages. So we need to find ways to find an entry point. I think we've learned that we need partners in communities who have shared identities and have established trusting relationships. And I think we've learned that we need opportunities to listen, for exchange, for feedback on our messaging, and not sort of this kind of feedback that occurs in public view in sort of social media landscapes, but other opportunities to learn from people and communities about how messages do or do not resonate. We can do that both informally, just by having lots of conversations with people who are different than us. We can do this formally by surveys and the kind of research methods that we engage in, and Julie will talk about with frameworks a little bit later. But again, I'll go back to this idea that finding common ground and shared values is a really helpful start if you can find a context for identifying those. And maybe the last thing I'll say here is, I work in public health and in public health communication. So I'm around people who think and talk about health and health impacts all of the time. And I think I myself, and I think others, can get into trouble sometimes because we assume that everyone else cares about health and well-being as much as we do, and put that first in our communication and messaging. But people care about a lot of different things, and health may not be first and foremost for them. So I think finding ways to connect public health to the other kinds of things that people care about on a daily basis can be a really important foot in the door strategy.
Right, right. And we also care about data, right? So practitioners often wonder how to balance data with emotion. So what does your research suggest about blending evidence with storytelling in ways that reach across audience?
Yeah, certainly data are important. I think data help us to identify strategies. They help us to prioritize limited resources. But from a kind of messaging perspective, humans aren't computers. We don't weigh evidence in a sort of purely rational manner. And I think that public health and medicine too often lead with data, ideas of risk, prevalence, et cetera. That's not to say data can't be a compelling part of what an effective message looks like, but I don't think it should be the entirety of a strategy. And I think, if we compare kind of health messaging to industry messaging around products that we know are harmful, I think we can learn a lot. So if you compare, public health communication to food marketing or alcohol marketing, I think they're quite different. Those industries, they lead with positive emotions. They emphasize tradition and fun and family, and they're selling a lifestyle, I think. And we're often leading with disease and death and fear and sadness. And that's not to say that, this kind of messaging isn't important. I think sometimes you have to break through the clutter a bit. You got to complicate these industry messages suggesting that their products only bring good things. But I think we in public health would benefit from incorporating joy and hope and awe in our messaging too, for showing how people and communities have come together to address problems that are facing their communities and their families. I'll also say that I think storytelling in particular can be quite helpful. It can make things that are abstract concrete. People sort of intuitively understand stories. It can invite connections with characters who are experiencing things that we may not be experiencing ourselves. That can produce, emotions, empathy, sadness we can feel with characters. But, I also think stories can individualize problems. We're really good in our culture at telling stories about beating the odds, pulling up your bootstraps, and fighting against systems that are challenging. And I think we're much less effective at telling stories about changing the odds through social and structural change. So, I think we need to also tell stories that center systems and sort of social change and not just sort of individual change.
Yeah, thank you. Thank you. We needed that. So if there is one practice or mindset shift that our audience could adopt to strengthen their communication work, what would you recommend?
Well, I find it very helpful to resist my initial intuitions about communication. We're exposed to messages all the time. We see things, we communicate regularly, but we often communicate with people who are similar to us. And those intuitions are driven by our experiences in communicating with people who are part of our daily lives. And those intuitions, I think, are quite helpful in helping us to navigate our own sphere, but they may not resonate in the same way with people and communities for whom we don't interact with on a regular basis. So I think it really speaks to the importance of getting to know communities that you're engaging with, learn beliefs, values, and concerns that people hold when we're sort of responsible in public health for a broad cross-section of the population. Again, I think we can do this through informal conversations, getting into the community. We can do more formal ways of learning, monitoring social media conversations, conducting surveys, or we can leverage other people's investments in this. We've put resources on the resource guide. I know Julie's going to share lots of super helpful resources as well. where organizations are conducting this kind of social listening. And chances are, people have asked some of the questions that help to identify the types of concerns that people have and the types of values that they hold related to our topics. So, I'll just say, sometimes my and everyone's intuitions are right, but sometimes they're wrong. And it's really helpful to, I think, just resist them initially and try to understand a bit more about the populations with whom we communicate before developing our strategy.
That's perfect. Thank you. Lastly, where can our audience go to explore, your findings or stay connected to ongoing research on media, messaging, and health equity?
I'll end with a QR code here, if I can get this up and running. You're testing my technological prowess here. Let's see.
Right.
All right. All right. So again, we have a website that has lots of resources, comhsp.org. We have messaging guides. We have evidence summaries. We have a resource library. We have a series of blog posts and things. And we also have a monthly newsletter that if you scan the QR code there, will get you signed up. And you can learn the latest research that we're doing on these topics.
Oh, well, thank you. And we will make sure to include those links in our resource guide. So, well, thank you, Jeff. And we will circle back to you during our Q&A. But now I would like to welcome Julie Sweetland. Hi, Julie. Great to have you here.
Hi, Soraya. Thanks for having me.
Yes, so let's dive right in. So many public health professionals are being asked to adjust their language, um, under these new pressures that we have. So from your experience at Frameworks, why does getting this framing work right matter so deeply for practitioners on the ground?
Yeah, I think all of us in the sector are more attentive to language right now precisely because of those pressures to change it. But framing has always mattered and always will matter. So by framing, I'll just offer a quick definition. I just mean making choices and about how we present our ideas that lead to significant, measurable, predictable effects in how people respond. And so figuring out how our choices affect the reaction we get is something that we take, very seriously at Frameworks because we know that the way the public is modeling an issue, the way the public is responding to an issue is a key driver in the policy environment and in the choices we make as a society. So what we say in the mission-driven sector or the public health sector, our communication, that changes public discourse. Like when we change what we say, we change what people hear. And that really matters because one of the strongest predictors of what people will believe is the number of times they have heard it. And so that really means it's important that our point of view, that the public health point of view is present and forward in that public discourse, because what people are demanding, what they want, what they will accept, what they will reject, all of that has a really significant influence on the way our institutions respond. So I have policy here on the screen, but it can be big P policy or little p policy. Any decisions people make in a group, right, to do or not to do something, we can think of as a policy. So we see its framing as the catalyst for continuously moving society, right, toward the place where our institutions are supporting health and well-being for all.
Okay, so I was looking on your website and you have some great resources. So you have the Communicating Now Framing for Health Equity Toolkit, and that distills a lot of complex research into really practical guidance. Can you walk us through your process and how do you move from research findings to real-world communication strategies?
Sure. So we're a group of social scientists and a group of social change strategists. And so our research approach is very similar to the type of work that Jeff was describing. Some differences, but same kind of fundamental approach, I think. We begin with descriptive research, understanding how people think now. And then we move into prescriptive research, how our partners, colleagues, coalition, and movement can use language and framing to spark new thinking. And so our methods there's more to this, but just as two examples, two main methods that we use is one is cognitive analysis of people's mental models, or sometimes you'll hear them referred to as cultural models or mindsets. And that this is really looking for the patterns in how people think about an issue. So we will interview, dozens of folks and look across those, thousands of 1,000-page transcripts to find the things that come up again and again, the assumptions or the silences that we see again and again. We then think about what are how do those assumptions shape people's opinions, their sense of what we should do as a society, and then think through what that means for our communications. So, as an example of that, two mental models that are really dominant in one that's really dominant and one that is necessary, and we need to amp it up a little bit. One is individualism. So, Jeff just mentioned this, the bootstraps thinking. This is just the sense that most social issues are about personal choices in the end. And it's not that that's completely wrong, but it's incomplete, right? And so another mental model that we document that people do have that way of thinking available to them, it just doesn't come top of mind always. It's the sense that what surrounds us shapes us, that context really matters. So our framing research, the next stage is like, how do we move people, from a strongly and exclusively individualistic understanding of the issue to that more contextual one. And so that's where the prescriptive work would come in. We'll design different strategies. We'll randomly assign thousands of folks to get a message that's frame A, frame B, or frame C. Maybe we want to talk about community, and then common good and interdependence as kind of our three guesses or hypotheses about what would move people toward that contextual understanding. And then we also have a control group. Then what we'd want to do is see, based on which version of that contextual thinking, what message how does that affect people's attitudes, knowledge, and policy preferences? And so when we do that, we can have a firm sense that any differences we see are about the framing and not what people thought when they got there. So an example of that in the Communicating Now toolkit was we found that framing health disparities in terms of a past, present, future story really broadened the constituencies and the groups who would align with very equity forward health and social policies. And we're certainly not the first people to think about how talking about history to explain disparities is a thing. Like that's a advocacy practice that's been around for, centuries. But we did find that the way we organize these makes a difference, and the way we explain these makes a difference. So, for instance, we found that if we simply assert history, assert that the past conditions affect health, it's statistically the same as saying nothing. You can see that on the left there. It's just zero, right? But if we explain how those past conditions and policies affect health, we can reduce people's sense of individualism. So what that might look like is something like this. On the left, this is asserting that history played a role. So we've got housing patterns that reflect past discriminatory policies such as redlining, and that's leading to increased health risks, problems like asthma, cancer, cardiovascular disease, and then an assertion again that communities of color face this disproportionate burden of lots of bad things, and that this is the cause of health disparities. Now, all of this is true, but it's a whole lot of what and not a lot of how. And we found that doing something more on the plain side, like on the plain side here, makes a big difference. So telling people how each thing affects the next. So starting saying we've got a lot of folks clustered by race and ethnicity in our neighborhoods. Why? Well, because we did redlining. And why does that matter now? Well, because we also placed factories and highways there, and that's more air pollution, and that affects people's lungs, hearts, and overall health. So it's not jumping over the history. It's really diving into it, not in more detail, but with more why. And so that's one way that we've moved from a conceptual understanding. We need to move past individualism to contextualism and get all the way into what do we say differently.
What a fantastic example. That it makes so much sense when you explain it like that. Thank you. Um, so, from a framing science perspective, what are the most common pitfalls that cause messages about equity to backfire or get misunderstood?
Great question. I think the most important framing lesson that any of us can take away with is how does our overall communication attribute responsibility? And what I mean is that the way we're explaining the causes of behavior, events, or conditions, because where we place responsibility for the cause has a big effect on how people think about what we should do about the problem, if anything. So here's an example of an attribution of responsibility where the advocates have said nothing. And this is a real example. I did not make this up. So every year, roughly 3,600 babies in the US die suddenly for unknown reasons. Researchers estimate that if expectant moms would just quit smoking, we could prevent 800 of those deaths. And so this is language that really places the responsibility on the mother there, and in pretty, I think, judgy terms. But we can, and so that is, a blaming sorts of responsibility. But we could, instead of attributing the cause to the behavior closest to the problem, we can reframe in terms of access or there are other ways to reframe as well, to be more structurally attributed. So here's an example that researchers estimate that if we just connected expecting families to treatment for nicotine dependency, we could prevent 800 infant deaths a year. And so that's putting the responsibility not on the individual, but on the system. It even broadens it out to not just the mom, but the family. And it talks about the nicotine dependency, right, which points to the companies rather than the behavior, right, of the smoking. Another pitfall is way too much data and no attribution at all. So Jeff mentioned this. Our data is a compass to point us toward the issues we want to work on, where the deep end of the issue is, and where we can get into it. But it may not be the communication, right. Maybe it's our social analysis. It might not be our communications analysis. So here's an example. Every day there's nearly 10 accidental drownings. That's 3,500 people a year. And within these numbers, we've got this startling fact that Black children are 3 times more likely to fatally drown than white children. And then why? It stops here. It just says that 64% of Black or African American children can't swim, as opposed to 40% whites. And so this does not state, it's not as judgy perhaps as the last one I showed, but if you don't fill in why are those weight rates higher, inability to swim higher in Black communities, you don't point to history or you don't point to current community conditions, people will fill in that blame themselves. So this is expecting the data to tell us, to shock people into a structural understanding. But what we can do instead is show and tell the actions that communities can take. We could talk about the history and community conditions as to why there are fewer pools, water safety, et cetera, in certain parts of the country. But here's, one reframe here, how CDC ended up messaging this, talking about how we need to ensure that there are public pools have diverse aquatic staff, access for people with disabilities, ensure affordability, and adapt the programs. I love this part right here with the different swim caps, right? Accommodating different kind of hairstyles and different, cultural preferences. So this is, pointing to the community rather than the population, right, being the problem. And overall, right, I think the biggest pitfall I'm pointing to here is treating our data as if it is the dish that we're serving people. We should be treating our data more like salt in cooking. That, if you add the right amount of salt, it brings everything together. It makes that communication, right, strong and powerful. And, but if you just hand people a spoonful of salt, they're unlikely to want to come back to you for more.
Great. Oh, you just gave some great examples, and I had another question about even more examples because that is so that's what folks want to hear. But I'm going to shift a little bit further because I talked with Jeff about how we are public health practitioners are having to shift our language, right? And it can feel, sometimes these language shifts can feel risky and they can feel even draining for communicators, for us here in public health. So, what challenges have you seen organizations face when adopting new framing strategies, and what helps them move through that discomfort?
Oh, that's a juicy question. So, it can be uncomfortable to change our language, even if we're doing it by choice. It takes some time to build new habits, to build new understandings of what we mean within our organization, our coalition, or our movement. So, I think just understanding that changes in language is a shift, and it will come with some discomfort. I think the bigger source of discomfort right now is that where we have folks who are intentionally trying to suppress certain types of topics in the public language and in the public square. And through various actions, cutting of funding, public threats, coded threats, not so coded threats, all of that is having chilling effects, right, on what people feel they can say. And so that could show up like generalized anxiety in an individual or an organization or coalition. Just communicating seems fraught and dangerous, and people aren't sure what to do. That can, be related to or lead to, a paralysis of analysis that people want to, because they don't see a perfect solution or, they don't want to do anything, right? Or they're more comfortable diagnosing and dissecting the problem to the extent that it stops or stalls action. And that's understandable, but it's dangerous and short-sighted for the sector. Because if there's a spiral of silence, meaning people of goodwill decide not to share their opinions or their perspectives because it seems unpopular, there's a fear of social reprisal. What that means is that that side of that point of view never gets into public discourse. And what's one of the strongest predictors of what people believe? The number of times they have heard it. So if we go quiet, all people hear are the loud, divisive voices. Now, as individuals, everyone should be able to, like, I'm fully for, like, people need to take a step back. People need to be quiet, right, for their own protection, safety, whatever that may be. But as a sector, right, we can't afford to let that happen. And so I think some of the fixes to that is to think about how we can manage in this politicized moment. So, what terms are being banned? Is that idea helpful and productive, like equity? If you can continue to use the term, if you're not under a ban, keep talking about it, right? But if you can't, that's okay. Find a close synonym. Either way, we should all be explaining it. No one word is the thing, right? It's the concept we're trying to get across, and we have ways to do that. And then remembering that framing happens a team sport, and so we need to be organizing with our allies. On the other hand, there are lots of ideas that are harmful and unproductive. So if loud voices are using awful terminology to describe certain groups, or ideas that are really harmful, like fake news, let's say that, we don't want to repeat that. We want to talk about instead about the intent, that we're concerned that we're eroding trust in journalism, and then we want to organize and strategize with allies as well. So an example of how you could talk about equity, for instance, if you are under, strictures from using that word, you can get the idea across without ever letting that particular word cross your mouth, cross your lips. And I think you could feel really good about what you're saying. So here's three versions of how to talk about health equity without saying the word equity. And for myself, I would feel like I wasn't pulling my punches. I was rolling with the punches, in this time, and just being strategic about keeping my ideas out there, even as people seek to suppress them.
Yeah, great. Oh, I could talk to you for so much more, but I know our audience has questions. Um, my last question that I asked Jeff also, for those who want to go deeper, where can our audience find more tools or resources to continue building their framing skills?
Okay, well, I've also got my QR code here handy. So the Frameworks Institute website, we make all of our research freely available to other mission-driven communicators. And it's not just research, not just straight data. There are toolkits and examples and other resources. The toolkit that you pointed people to earlier, that's the QR code on the left, and that really is organized by like all these challenges. How do I think about my audiences right now? What do I do when my word gets banned? How do I talk about kind of newly controversial topics like vaccines? So that's all there. And so if you want to do that, that's great. We've got a newsletter, but you also can find us on social for the Cliff Notes, adorable versions of the very nerdy research that we do all the time.
Oh, perfect. And we will make sure we include all these resources in our resource guide. Oh, fantastic, Julie. Thank you so much. Um, Joanne, I am curious about our audience's questions. What do you have for us?
Thanks to our presenters. We have some questions, and I will say that they could probably fill a whole nother webinar to answer. So I'm just going to ask
I'm
Jeff
sure.
and Julie to keep that in mind as we try to address as many of them as possible. But Jeff, I'm going to start with one that I think is pretty straightforward, and I think one person asked it in the Q&A box, but I think it'd be helpful for others to just kind of hear you explain the difference between when you say centering audiences as maybe focusing or selecting a target audience.
Yeah, thanks. Yeah, when I use the phrase centering audiences, I was referring to really trying to understand the values, beliefs, and kind of situation that a particular group with whom you're communicating is in, which is related to, but is different than the idea of sort of specifying different audiences, which I think is a broader question of resources, of strategy, right? So if we're trying to message about a particular health topic, chances are in public health we have far less resources than the tobacco industry, for instance, or the food industry. So we may have to make choices about whether to do a broad overall population kind of campaign messaging or focus on a particular audience. Whatever audience you pick, though, then understanding their sort of where they're coming to the issue from, how they think about it, what they value, I think is really important.
Yeah, that's helpful. So it's the step after selecting your audience and making sure you really understand them and focus on their needs, perhaps. That was helpful. Thank you. Well, this question is for Julie, and you had mentioned, I think it was you that mentioned, use the term access attribution.
Yeah, so I was talking about, where are you attributing responsibility for a problem? Is
Mm-hmm.
it a problem in the
Right.
person's behavior, the population's behavior, or do you want to point toward an issue of access?
Mm-hmm.
Could be
So
other things.
I thought this was a really interesting question, and it's, goes back to sort of how, particularly those of us in public health, and perhaps other fields, we get data from sources and they are sort of framed sometimes in a way that could sound blaming. So this person who submitted the question said, with the example of, maternal mortality rates in the African American community, where Black women are 3 times more likely to die in childbirth, what's a way that we could make sure we're kind of reframing that?
It's so funny. That was an example that I actually had that in my deck, and at the end. So let's
Perfect.
look at the bottom here. So here it's not that I would, okay, Black women are up to 3 times more likely to die from pregnancy related health complications, even when controlling for other factors. That's data, and it is, I'm not saying it shouldn't be in the communication, right? But it's some of that salt. If this is the only thing we say, people will fill in blame and othering, right? We could start with a sentence like this: every expecting mother, should receive safe, respectful maternity care. And we need to change the fact that Black women can't count on this essential care. Give some
Mm,
examples of this, and then talk about how those gaps in our collective caregiving helps to explain why Black women are 3 times as likely, right, to die
yeah.
from those complications. And so it's really about putting the data in context. And in this case, it would be the access and availability and reliability of safe, respectful maternity care.
Perfect. That's so clear. Well, this webinar attendee kind of ha teed that up perfect for you, Julie. All right. Well, this question is sort of related, and I'd love to hear what both of you think. One of our attendees just kind of commented about how in public health, the CDC, used to be a very trusted source of data that then we could use some very research-backed communication approaches and strategies to use that very reliable data. And now the data that's available through the CDC has changed, and what they're able to put out there and what they do put out there has changed. So just kind of your thoughts about that, that could help some of our practitioners in the audience figure out, where to even start with data that may not be true, may need to be really reframed. Jeff, do you want to start with that one?
Yeah, it's such a heartbreaking time. I'll just acknowledge that as one who has made lots of use of CDC data. Trust in federal health authorities has been declining over time, predating the current administration. But I think what we're seeing in this moment is really nothing short of tragic. I don't have great answers for you at this moment, frankly. I do think the idea that we can sort of refer to the CDC as a quote gold standard at this moment is not something that I personally feel comfortable referring folks to. So what I'm trying to do is identifying other potentially credible sources that are not non-governmental organizations who may also share some of these kinds of recommendations and data. It's not going to replace what the CDC does, but people have trust with organizations like the American Cancer Association, American Lung Association, who are not governmental entities and sort of are not necessarily subject to the sort of ideological framing that is happening now. But I'm curious what Julie thinks about this too.
Yeah, don't agree that it's heartbreaking, troubling, and that there is no perfect answer. Yes, looking to other credible sources, is something we should all be trying. And the moment we're in is voices are working to discredit all kinds of institutions. And so that's a temporary essential measure, but it can't be the only thing. What I might add in the short term is that it really challenges us to spell out mechanisms, right? We don't need to be citing footnotes and leaning on the credibility of another organization, but getting better at helping people reason for
Mm,
themselves, help explain, and they can understand why one thing is affecting the other. Then that need for external credentialing, I think, is a little reduced. At the same time, we've got to figure out ways to defend the idea that our government, we can expect and demand a government that is honest, transparent, trustworthy, et cetera. That's
Yeah.
part of our story as well.
Yeah. Very helpful. Okay, this again is would love for both of you to comment on, and it's really about storytelling and just sort of tips that you can provide on what would make storytelling effective specifically for social change as compared to storytelling for behavior change. And I think, Jeff, maybe you made that distinction first.
Yeah, again, I think we're really good at telling stories about overcoming obstacles through sheer force of will and exceptional, human capability. And really, I think the stories that public health needs to be telling is stories of structural change. And so, one of the ways that we go about doing this is we try to show how a character, despite their best efforts, despite sort of taking responsibility and making an effort, runs into insurmountable barriers that are community or sort of structural or organizational. That's sort of an important piece. I think a second piece is talking about strategies to overcome those policies that would change those barriers, that would reduce it. We often just stop at saying, oh, these are structural barriers, and assume that people are going to fill in the blank and say, therefore, we need to sort of remove those barriers, when a lot of folks say, well, therefore you need to try harder. So I think we need to do a better job of showing that these are not immutable things that we can change through policies, through organizational change. And I guess the last thing I would say is we found in our work that you need to scale up. That is to say, to show that a particular character in a particular community and situation is not alone, that this is something that's happening in lots of places across the country. Data actually can be quite helpful for making that case, again, as a sprinkle of salt, but not as a full plate, as Julie so eloquently put it.
Mm. Julie, you gave a thumbs up. Do you want to chime in?
Well, yeah, thumbs up to everything Jeff just said. I feel obligated to add something. So I would that in our storytelling for social change, we as advocates are often relying on a story that we are in a dark and gloomy night, right? That a dark and stormy night, that things are so bad that I need you to come along with me to fix these things. We need to talk about problems. Otherwise, why do we need solutions? But we are seeing right now, Americans are struggling to see any positive future for America. And so, one essential storytelling intervention is to paint the beautiful picture, as some of our colleagues in this space call it, an aspirational end state. That what will it look like when we get public health right? What will it look like when we remove some of those barriers, when we right those historical wrongs? Helping people see a future worth living in is really important right now. Without that, we're seeing people being willing, just wanting AI to fix it, wanting a charismatic leader to come in and do it for us. And so it's a really important part of storytelling for social change right now.
Yeah, well said. Well, Soraya's back, so we are out of time during this webinar for Q&A. But remember, folks, if we didn't get to your question, you can head over to the discussion group, and Julie and Jeff will be joining us there. Soraya?
Yes. Oh, thank you, Joanne, for managing the Q&A and facilitating that fantastic conversation. Those were some great questions. We love hearing from you. Your feedback really means a lot to us. So please take a moment to complete the brief survey that Erin is sharing in the chat. We really do read each and every comment. And then we hope you will join us next month in honor of the National Day of Racial Healing. We explore how laws, policies, culture, and norms influence the health of immigrants, migrants, and our communities. We will hear from Dr. Elizabeth Aranda and Ivy Suriopas as they unpack shifting legal protections, lived experience, and solidarity-driven strategies for advancing health equity and policy change. And Yes, if you want to continue the conversation, please plan to continue the discussion with us, with Jeff and Julie and Joanne, and join us for the post-webinar discussion. And Joanne will lead that discussion group, and Erin will drop the link in the chat so you can join us. So this concludes our webinar. I want to thank our guests, Jeff and Julie, again for sharing their expertise. And to the audience, thank you so much for joining us today. We really appreciate your time and your engagement. And we hope to see you in either the discussion group or next month in January. Bye, everybody.